Good morning, ladies and gentlemen. Thank you, chairpersons. I think we are 50 minutes behind schedule. So I'm going to start my lecture right away. I would thank Dr. Shamsa, Dr. Shrijit, and Dr. Anand for their hospitality and for having taken care of us and inviting me to this scientific session. So my topic today is monitoring and managing hepatic diseases and anesthesia. So I am a little confused how I can combine monitoring and managing. So I'm just going together as cases. So at the end, if you have clarifications as to some particular form of monitoring I've left out, I'd be happy to answer. So basically, when you talk about hepatic diseases coming for anesthesia, you need to realize that the entire spectrum, it's multifactorial. You have congenital liver disease, metabolic, traumatic, inflammatory, infective, neoplastic, as well as the degenerative forms or cirrhosis as they are called, which is emerging to be a very important part of presentation of patients with either inadvertent or recognized liver disease coming for surgery. So I'm going to start off with a little case of a child. That's the congenital forms, biliary atresia. I'm sure most of the postgraduates here would have exposed themselves to this case. A 2-month-old baby is brought with increasing jaundice and clay-colored stools. His hemoglobin is about 9.8, platelets are 2.74. The bilirubin is a total of 8.6, conjugated is 6.8, and the INR is 1.74. So what amongst this actually worries you so much? Hemoglobin, bilirubin, or the INR? Right? So this is typically a picture. These children are actually quite well. And the fact is, if they are brought for a Kasai procedure, which is essentially a portoenterostomy, at this time point, the liver functions are well preserved. No, your worry essentially is the obstructive jaundice. So these are figures which I have talked about in most conferences. Essentially, bilirubin, which comes from the red blood cells, is carried by albumin into the hepatocyte. And here, it's carried by membrane-bound proteins and undergoes conjugation at the endoplasmic reticulum. So when you have an obstruction to the passage of these conjugated bilirubin into the enterohepatic circulation, you have the consequences of the failure of passage of bile into the enterohepatic circulation, and therefore a failure to absorb fat-soluble vitamins, particularly A, D, E, and K. And vitamin K is essential for the gamma carboxylation of factors 2, 7, 9, and 10, wherein it converts them from an inactive to an active form. Second is the bile salts are actually excreted across the biliary canalicular gradient into the intestine, where they get emulsified to form the bile salts that play a role in fat absorption and fat metabolism. So all forms of obstructive jaundice are associated with an abnormal lipoprotein at the level of the hepatocytes, which predisposes to the occurrence of some form of systemic inflammatory response or a distinct form of sepsis in these type of surgeries. The bile salts, the high levels of bilirubin that are circulating, causes an osmotic load on the kidneys, and you need to keep this child hydrated because otherwise they might get some form of kidney injury. And the last, you definitely don't see this in children, you can see it in an adult with obstructive jaundice, is its competition with the binding sites and cardiac myocyte, impairing contractility. So briefly, I'm not going to go into the types of biliary atresia. It's a type 3, which is most common. The surgery that is done, if you have appropriate biliary canaliculi that you can anastomose to the jejunum, is called a portoenterostomy. The division of the liver is at the level of the hepatic hilum, where the portal plate is exposed and a Roux-en-Y loop of jejunum is taken. As far as anesthesia, the one thing I would like to do for this child is to correct the INR. So this does not require FFP. All it needs is an administration of vitamin K, which is given intramuscularly or intravenously, as whatever your institutional practices are, and more or less with 2 doses or 3 doses, the INR is corrected. When the INR is corrected, this child is not a contraindicated candidate for the use of caudal or even caudal catheters. I do not use caudal catheters. A single dose of caudal is what I might use for this surgery, and this definitely supplements an opioid analgesia. The rest of the thing is just to look at the blood glucose, allow an appropriate fasting if your surgeon allows you to give that a drink of apple juice 2 hours before surgery. You don't need to have additional fasting. So we do ask for it. They do ask for a central line because it is a biliary to the bowel anastomosis. The child is likely to be kept NPO for some time. Therefore, you do need a central line under an ultrasound. Coagulopathy does not seem to be a problem. The liver functions are good. You can induce with propofol. You can intubate with cisatracurium or atracurium or whatever is a practice at your institute. Maintain with oxygen, air, and SIVO or ISO. And then reverse at the end of procedure. And you can avoid or reduce the opioid by using a caudal analgesia with local anesthetic. You may like to add an additive. I used to use clonidine, stopped using it these days. Right? Surgical troubleshooting here is if the surgeon cannot find a duct to anastomose to the bowel, or if the child gets a preoperative cholangitic inflammation, or if the child is actually allowed to, that's why I said a 2-month-old child when I put the history. So the ideal time to do this is before about 65 days. After this, actually the fibrotic changes may actually encompass the biliary ducts, making it unsuitable to do a diversion procedure. And therefore, this child may not be a candidate for Kasai, but may need to go for a transplant. And even in a child whom you have done a Kasai, the Kasai may fail. And the manifestation of this is high levels of bilirubin. I think it's above 5 or 6 milligrams that progress beyond the 3rd or 4th month would mean that this child is going to have a failing liver and is likely need a transplant later in life. So a similar presentation is another congenital condition called choledochal cyst. This happens in an older child. Principles of anesthesia remain the same. Now, what happens if an adult gets an obstructive jaundice? This is a very famous PG question. Patient 60-year-old comes with a periampullary carcinoma. He has yellowish eyes. He presents with itching. And on asking, he says he has clay-colored stools. So you have a difference. The sites of obstruction when you can get obstructive jaundice. Very commonly, a patient coming for Whipple has a periampullary carcinoma. But you must remember for obstructive jaundice, the sites of obstruction can occur anywhere. Right, left, hepatic duct, common bile duct, at the cystic duct, and at the point where it enters into the small bowel. So different points, and sometimes if the candidate cannot go for surgery, a palliation with an endoscopic retrograde cholangio pancreatography is often done. So factors that will increase morbidity in a patient presenting with obstructive jaundice are malignancy as an etiology. So if you had a benign stricture or a stone, it is a better situation to tackle than malignancy. Associated malnutrition, this means that the liver's synthetic function or ability to secrete albumin is gone. Azotemia or a decreased renal function to me is a single most important poor predictor of outcome. Increase of age and increase in intensity of jaundice similarly carry poorer outcomes. Right? Anesthetic concerns when this patient is to come for ERCP. Once again, his INR could be prolonged, and even if it isn't, it is prudent to give vitamin K because of the obstructive jaundice. Fat-soluble vitamins may not be completely absorbed. Look to see if he has any evidence of hepatocellular failure. In an uncomplicated case, the liver functions are normal, even though he has an obstructive jaundice, bilirubin of 20, direct of about 15. His liver functions, as judged by AST, ALT, and albumin, are likely to be normal. Right? So the only thing you need to do is to give vitamin K. Now, what happens when you take this patient to the ERCP room for a procedure? Now, 2 things you need to remember is that you need to keep the patient appropriately fasted. You can tell them to give clear fluids. Patient may be scheduled at 9 o'clock, but he reaches the lab only at 2 because the first case got complicated. Remember that he should have appropriate IV fluids to avoid dehydration for the same reason that I told in the child. The other important thing is that when they relieve the obstruction by stenting, now this is a place which is teeming with gram-negative bacteria, which is a normal this thing of bile. You open it, the sudden release of a biliary obstruction produces a bacteremia that may sometimes lead to a bacteremic sepsis and a septic shock. So you need to be prepared to resuscitate. It can happen in the most unexpected situation. You'll suddenly find there is tachycardia, the temperature is rising, the BP is falling. Well, he just needs support. He may need an arterial line. He needs resuscitation with fluids and norepinephrine. Maybe you don't want to ventilate, extubate him immediately. And if you were doing it under sedation, you may want to ventilate, observe him, and then extubate. So remember, that is one more complication that can happen. So acute tubular necrosis and dehydration, biliary sepsis and bacteremia can occur. And the third thing that is likely to happen more in this group of patients is the negative inotropic effect of the bile salts by competing with the binding sites of administered vasopressors and inotropes. So it impairs the rate of rise of action potential, and you may get less than an expected response in the rise of blood pressure when you may use your vasopressors or inotropes for the treatment of shock. So this again, the renal dysfunction, I've mentioned about it and I'm not going to repeat it. You need to hydrate. Is mannitol renoprotective? Well, I'm not sure. There are people who speak for and against. If in doubt, you can use a small dose of mannitol, about say a 0.5 grams per kg, that is given just before the procedure to make sure that you're not in trouble. Right? And as I said, bile salts can have a negative inotropic effect and reduce the peak action potential. Another thing is that in obstructive jaundice, there could be a decrease in SVR, and the hypotension that occurs in the case of a biliary sepsis following release of obstruction may actually be exacerbated in this group of patients. Now I'll come to another group of patient. Is a patient who's been seen in PAC clinic. His CBC is okay, platelets are okay, INR is okay, albumin is okay, and you take him and the surgeon puts a scope for a laparoscopic cholecystectomy, and you may see a serotic liver. So is it always possible to identify a liver disease, that too in a stage of child A or a low MELD? You may not have jaundice, the platelet counts could be essentially normal, there is no pedal edema and ascites. You can miss this on clinical examination, and this becomes an incidental diagnosis at laparoscopy. So also the condition of fatty liver or steatosis can be completely missed. We don't always do AST, ALT when a patient comes for lap chole. But this patient may have had this metabolic syndrome, high lipids, and you may find a grade 2 or grade 3 fatty liver. What does it mean to you? In this case, you need to be cautious about the administration of both intravenous agents and inhalations, and they could take a far longer time at reversal and extubation. I've had this incident when I was much younger. Lady coming in for lap cholecystectomy, and I was used to vecuronium about 12, 13 years ago. Gave her about 5 at intubation and then repeated with 1 at 40 minutes. And this was at Mumbai, where every hour counts. Is Dr. Indrani here? She's left. So every hour counts. And in the end of this case, the patient could not be extubated. And the surgeon was saying, you stay here longer, the patient's going to be billed more. So I actually extubated the patient, ambooed, took her to the ICU and put her on a BiPAP to save my face. But this is something probably I didn't understand the consequences of fatty liver then, but I do now. And you definitely need to titrate. We have better agents now. I would have used cisatricurium and probably got away with it. But do not use rocuronium saying I used, and your patient is not going to wake up at the end of this surgery. Can we use paracetamol? This is a controversial thought that comes to many people. So even in patients who've had a transplant, it's okay to use paracetamol. So what you need to understand is a mechanism of toxicity of paracetamol is because of its metabolite, NAPQI, right? And this metabolite is cleared by glutathione. So if you have adequate stores of glutathione, or you can actually supplement glutathione in the form of N-acetylcysteine as a prophylactic, it may be okay to give slightly less than the recommended safe dose of paracetamol in patients who may have had mild degrees of liver dysfunction. You will get away with it. There will not be any problem. Now, coming to the last topic, is the CLD proven liver disease or serotic coming for incidental surgery? Now, when I asked, did we do any cases, my students sent me this. Patient, 45-year-old, revision TKR, previous road traffic accident. He's had femoral plating and 1 knee replacement. He is a known child A cirrhosis with an alcohol as an etiology. His platelets are 116,000. Bilirubin is 1.12. She's not mentioned, but I'm going to put it. Albumin was 3.2, right? INR is 1.2. But what adds to more problems are, he has a history of chronic pulmonary thromboembolism, and by transthoracic echo, his right ventricular systolic pressure is 70 plus right atrial pressure. He obviously has portal hypertension, for which he has been put as propranolol. Propranolol is a pharmacological agent for the reduction of portal pressures. He has had ascites, and therefore he is put on an amiloride furosemide combination. And I'm not sure whether sildenafil was started prophylactically or if they actually measured the portal pressures, because to call it portopulmonary hypertension, you need both a mean pulmonary artery pressure more than 25, and a pulmonary vascular resistance that is more than 240 dynes. So whatever reason, this patient was on all three, and an ultrasound report that he had from another hospital says he has had ascites and grade 1 varices on endoscopy, which is the reason why I cautioned when yesterday's discussion was of a child serotic coming for GA, and my postgraduate said that she would put a Ryle's tube. You need to exercise, I will finish it in 5 minutes. You need to exercise a lot of caution because the portal pressures cannot be predicted, and you don't know the date when he's last had this endoscopy. So all you need is to shove in the Ryle's tube with a little less care and you'll have a torrential bleed. I have had the experience of having a massive GI bleed on a patient coming for transplant on the table. And this patient had to be taken for an emergency TIPS procedure. And then he came in for a transplant, I think, a week later. But it is a huge morbidity and a huge financial implication, and you need to be cautious about it. So trainees never put the Ryle's tube in a child serotic. Ask your consultant to put it. For one, they could be technically superior, and two, the blame is off you because they will say you are rough whether you are rough or not. Okay, so any patient who gets cirrhosis just needs little to decompensate, and as the time evolves, the risk of decompensation increases. This could be in the form of variceal hemorrhage, it could be in the form of ascites, encephalopathy, or jaundice. And this is what I was trying to exercise caution when I said be careful when you put the Ryle's tube. Those blue arrow there's a worm-like thing, which are the portosystemic collaterals and huge varices at the gastroesophageal junction. Now, technically, they are supposed to be submucosal. So when you're putting your Ryle's tube, you don't touch them. But it is possible there is an abrasion of the mucosa. And if you touch those varices, which are at very high portal pressures, they could be 15 to 20 millimeters of mercury, you're going to have something like a mini arterial bleed happening out there. Right? So this is a picture that actually shows the various sites at which the collateral circulation occurs. And ascites is a manifestation of decompensation. Why it occurs in a serotic is because, you know, the hepatocyte in the space of Dicey. The endothelial cells, the Kupffer cells play a role in defense. And in the space of Dicey, you have those cells which actually play a role in lymphatic reabsorption. When that becomes obstructed, there is a back pressure, and this causes the ascites to accumulate. This is one of the postulated two mechanisms. So when you see ascites, the patient has already decompensated, and you wonder whether this patient needs a rapid sequence induction. Tense ascites is an indication for rapid sequence induction. Controlled ascites, it is at the discretion and experience of the consultant. Variceal hemorrhage, I think I've spoken enough about, and I'm not going to do it. So any child C serotic coming for elective surgery has a propensity to develop encephalopathy. What happens is the hepatic functions which are already compromised get compromised further. There is a failure of the urea metabolism and the failure to metabolize ammonia, which actually bypasses, enters into the brain, causes astrocyte edema if it is in an acute liver failure, but causes milder forms of hepatic encephalopathy if it were a more chronic situation. Cardiovascular system in a CLD is compromised. There is an increase in extracellular volume. There is a hyperdynamic circulatory state. The blood pressure is actually reduced in these patients. They have a negative chronotropic as well as inotropic. There's a chronotropic incompetence and a negative inotropic effect. Typically, blood pressures are low. The SVR is low. If you measure the SVR by whatever method, it could be 700 or 600 as against the 900 to 1200, which is normal. Then they have a tendency, because of the hyperdynamic circulatory state, to develop left ventricular outflow tract obstruction. Coagulation has been discussed with yesterday. There is a rebalanced coagulation of both the procoagulant factors, which occurs at 3 levels of coagulation. 1 is platelets, 2 is the coagulation factors, and 3 is the fibrinolytic system. So this is a patient who is posted for a liver transplant, and if you actually look at her hands, the right hand is completely swollen, and this patient has evidence of upper extremity deep vein thrombosis with a platelet count of 47. So this is what I'm trying to highlight. The rebalanced coagulation can push either towards bleed or to the formation of thrombi. Right? So the patient with CLD, as I said, may come for TIPS, which is a transjugular intrahepatic portosystemic shunting. The only major contraindication you always need to remember is a contraindication TIPS is right heart failure. because you're pushing the blood from the portal into the systemic circulation, and if the systemic circulation is already volume overloaded, you will precipitate a right heart or a congestive heart failure. Can we do other kinds of surgery in serotics? Cardiac open heart surgery in child C serotic, probably no. Child B, you need to be extremely careful, understanding a risk for decompensation. So for general surgical profile, I think Dr. Kishore correctly pointed, the risks are coming down as with better understanding and expertise. But for cardiac surgery, I think they say 20% incidence of morbidity if it's child A. Child C, nobody would take for a cardiac surgery. Couple of minutes more and I'm done. Percutaneous coronary interventions in cirrhotics is being followed more increasingly now, because you're finding transplant patients with probably steatosis or fatty liver as an etiology having associated coronary artery disease that may not manifest by routine investigation. So they do put a stent. You do have to wait for any problems associated with antiplatelet therapy. But if it is considered life-saving, then we do go ahead with a coronary stent in this group of patients. Abdominal surgery, this is a picture of lap chole. I'm not sure if it's clearly represented. This is a commonest surgery that we see in child B cirrhotics. And if you pay adequate caution to the amount of drugs, titrate the drugs, careful use of drugs that are easily eliminated and do not have, are not dependent on end organ metabolism, patients come by quite well. And this is the case like we discussed yesterday, an umbilical hernia, small hernia with ulceration, a rectus sheath block that is given bilaterally, or you can even extend it as 4-quadrant, works very, very well. You may need to supplement with a little IV dexmedetomidine, but most patients tolerate this, and I myself have done a number. Occasionally, the patient may be uncooperative. Right? Or if the hernia is very large and ulcerated, there's no space for you to give the block. So these may be conditions where you actually wonder if it is worth taking a risk of anesthesia or just leaving it like this. Our experience in child A, we have done hepatectomy, esophagogastrectomies, nephrectomies in child B, cerectum in child B. And the factors that really prognosticate a poor outcome are emergency surgeries, abscesses, and vascular surgeries have had a poor outcome amongst our experiences. Right? To summarize, incidental surgery for cirrhotics is increasing, and the multisystemic manifestations of CLD must be understood and corrective measures planned before surgery. The availability, I'm sorry, I really could not touch upon the monitors, but the availability of advanced monitors and better and newer agents have increased the margin of safety. The availability and expertise with ultrasound has improved safety with vascular access and blocks. Multidisciplinary care and performance of surgery in centers which have experience with transplant may improve outcomes of significantly ill patients. Thank you very much.
Thank you, ma'am, for the informative session. The topic is open for discussion. Any questions? Ma'am, for your first case, for Kasai procedure, do you practice ERAS, the carbo load? I would like to know.
So children, we don't give carbo load. This is a 2-month-old child, but we give apple juice. So my only problem is a surgeon and their orders. Their orders always overrule yours. So they may just write an order, say NPO after 2. They do put an IV drip with Iviolite P, which is a 5% dextrose. But we are again have done studies where we found nearly 40% of children who come to the OR have blood sugars less than 70.
Yes, let's see. Then, ma'am, what point of care monitoring you advocate for an incidental surgery in a CLD patient, the TKR patient?
Yeah, the TKR is child A. I think I would probably if since I have a facility, may just do a thromboelastogram, and I would probably believe it's likely to be close to normal in this patient. Okay. I think they always use tranexamate as a prophylaxis. So I think they would start it just like how Krishna said, other than cataract, he's used it for everything. Thank you. I think so. To child A, the coagulation is going to be normal, and I would have gone with regional anesthesia in that patient given the multiple risk factors that he has.
Ma'am, can you, what is the advantage of ROTAM over TEG?
Kishore should answer that question. ROTAM is a more sophisticated version and has more specific reagents. Having said that, you have something called the functional level of fibrinogen in the thromboelastogram. So when you do a rotum for transplant, you essentially use only two things, FibTem and XTem. Right. So thromboelastogram, if you want me to point out difference by difference, rotum more sophisticated. Rotum allows a pipetting, so the handling of the samples is better. Very reagent specific assays. And they say even in 10 minutes, you have an indication of the coagulation failure vis-a-vis the thromboelastogram, which may take up to 30 minutes.
Thank you, ma'am.